Hello and welcome to another Top Doctors online interview with one of our leading specialists. Today we are honored to be joined by Miss Tania Cubison, a highly respected consultant plastic surgeon who will be speaking to us about targeted muscle reinnervation. So thank you very much, Ms. Cubison, for taking the time to speak to us today. Would you like to introduce yourself?
Thank you. As you say, I'm a plastic surgeon by background, but over the last 10 to 15 years, I have specialized increasingly in the management of amputees and their pain associated with being an amputee. And what we'd like to talk to you about today is a very new technique called targeted muscle reinnervation that has come onto the scene of pain management for amputees over the last couple of years. And I just feel that it's very important that everybody knows everything about it and how it might be helpful to the management of amputee pain.
Okay, perfect. Thank you very much. So with that, we can start with the first question. Could you explain what targeted muscle reinnervation, or TMR, is and how it works, please?
Okay, so targeted muscle reinnervation, or TMR, is about taking a nerve that is not working properly, that is reporting pain to the patient's brain, and giving it a new job to do so that we can remove or reduce the amount of pain that they get, either perceived in the stump itself, the residual limb itself, or indeed perceived in the part of the limb that's been removed, what we would call phantom limb pain. Targeted muscle reinnervation is a surgical technique. It means opening up the limb, normally a little bit further up the leg than the end of the stump, and finding the nerves that are supplying the residual limb. Now, some of these nerves are motor nerves, nerves to the muscle, and these nerves are involved in maybe making the footwork, maybe making the leg work, and many of those muscles are no longer in use if we do an amputation. So we have some spare muscles that aren't doing anything. You then have other nerves that are sensation nerves, and these nerves, if they've been cut, misfire. Sometimes they misfire if they've been touched, a very sensitive end to the nerve, which we call a neuroma. And sometimes they just misfire, even if nothing touches them. And sometimes this gives the sensation of phantom limb pain. Now, what we have found out is that if you join together the nerve that is giving the abnormal sensation and a redundant nerve going to a muscle, you can give that sensation nerve somewhere to go and something to do. And this results in a change to the phantom symptoms. And also it means there's no longer a dead end of nerve at the end of the sensation nerve that when you touch it produces acute electric shocks. This end of nerve is sometimes described as a neuroma, being a little lump on the end where the cut nerve is trying to heal. So TMR allows us to manage both the phantom side of limb pain, but also the sensitive nerve ends or neuroma, both of which are managed by a fairly straightforward operation that takes place a little further up the limb than the end of the stump.
Okay, well, very interesting. And could you tell me what the advantages of TMR are over different types of treatment for nerve pain?
So for a long time, we have managed neuroma pain by simply dividing the nerve. But then, of course, as soon as you cut the end of it off, it will start to try and heal again. So you end up with a further neuroma. So if you simply cut the neuroma off, then it will form again. Sometimes it takes 18 months or 2 years to do so, but it will come back. Mm-hmm. We've tried over the years doing other things like burying those neuromas into a piece of muscle, putting them somewhere further away than they were before, to try and get them out of the area where they become a problem when they're sensitive. But at the end of the day, the nerve still grows inside a healthy muscle and is cushioned by that muscle. The difference with TMR is we're actually cutting the nerve to that muscle and physically joining the sensation nerve to that muscle. So we're doing a nerve to nerve joining up, which is why the nerve grows properly into the muscle. And indeed, you can see the muscles twitching. And that tells you that that nerve is doing something useful. So when the patient was getting nerve pain, what they now have is the ability to twitch part of their residual limb that they didn't have before. Okay. And TMR was invented because we wanted those little areas of muscle twitch to trigger a myoelectric prosthesis. So the myoelectric prosthesis was put onto the limb, and then the socket was able to pick up twitching in the residual limb. And what we found was all those patients didn't get neuromas, or less of them got neuromas, and they didn't have phantom limb pain in the same way. So we said, even if you're not trying to power your prosthesis, it would still be a good idea to do this because it would reduce your risk of getting phantom limb pain. So that's where it all started. And that's why it's called targeted muscle, because to start off with, we were trying to get a specific muscle involved.
Okay, very interesting. Sounds a bit sci-fi almost, the prosthesis twitching with the nerve.
And they can, the upper limb prosthesis were able to get 12 different sites across the shoulder to enable this prosthesis actually to work much more than just the old like this. Okay. So it was a very important step and has been associated with real changes in function for particularly upper limb patients. But the side effect of that is the lower limb patients with phantom limb pain have now got a method of treatment. Whereas, to go back to your initial question, that was the treatment for neuroma, to bury them or to cut them. The treatment for phantom limb pain, well, there really haven't been effective surgical treatments for phantom limb pain. There have been treatments like tablets, like nerve stimulators, and other such things like mirror boxes to try and reprogram your brain. But we've never really had a good surgical treatment for phantom pain before TMR.
Okay, perfect. So it's a real revolutionary technique in treating nerve pain.
Absolutely.
Perfect, thank you. And who would you say is a suitable candidate for this treatment?
Well, to start off with, the treatment was established with young, fit, healthy military patients, in fact. But in my practice, we've been using this for a huge number of different types of patient. What we do is confirm that there is a problem with that nerve by using an ultrasound guided local anesthetic injection to confirm that taking that nerve away would improve the patient's symptoms. And then the operation is offered to the majority of patients. We are still a little concerned about the group of patients called complex regional pain syndrome, because any surgery on these patients can result in making the symptoms generally worse. However, even in some of these patients, TMR has been effective. The difficulty with it is that it takes a long time to work. So people have to be prepared to wait and see on the results for a number of months, sometimes up to a couple of years before they get the full benefit. So it does take a little bit of time to settle. The majority of patients would need to be fit for a general anesthetic, but we have done this operation in some cases under local anesthetic or under regional block, such that it is available for patients who are even really not that very well.
Okay, amazing, thank you. And Could you tell me what the success rate is like for this treatment? Does it seem to have good results in most people who undergo it?
It does. I mean, as I said, the difficulty is that for some people it takes a very long time. I
Mhm.
started doing TMR in mid 2019, so not that long ago. And we have some of the early patients who we thought weren't going to get benefit, who actually are now getting benefit quite a long time afterwards. So the majority of patients will get at least 50% improvement in their symptoms. So it doesn't take you to being pain-free, but it takes you from being unworkably painful to manageably painful. And we have a number of patients who have stopped taking pain meds and gone back to work. They're not pain-free, but their life has been put back together again following the TMR procedure. So overall, I think it's very effective. And I now offer it routinely for anybody for whom I'm carrying out an amputation so that they don't have to have the phantom pain first before we then offer the treatment. So very successful in the majority of cases.
Okay, brilliant. Thank you. I think you've touched on this already, but what is the recovery period like after
So,
receiving this treatment?
so the operation would normally be carried out as an inpatient. Then patients would stay in hospital for a few days in order to have their pain managed. We use some continuous, like a drip with local anesthetic going into the operative site to numb the nerve for a few more days once it gets used to the idea of having had the nerve repair done. And then it would normally take a couple of weeks until the wounds are healed. But then the reinnervation phase, the regrowth of the nerve, can take anything from 3 months to 2 years. And during that time, I would expect the patient to get back onto their prosthetic limb after about 4 to 6 weeks. So a week in hospital maximum, and then a couple of weeks with the wound healing, 3 months to being back on legs again. And many of the patients are back on legs at 4 weeks. So it can be a lot shorter than standard surgical treatment of the stump because you're operating further up the leg rather than on the weight-bearing surface.
Okay, thank you. Sounds great. And would you say that this surgery is the future of treating nerve pain?
It definitely seems to be at the moment. I think there are always changes, and there are patients who I discharged from my clinic 5 years ago having said, I'm really sorry, I don't have an operation for your phantom limb pain. I will get you know if anything happens. And at the time I had that conversation, I genuinely didn't think there would be any way I would have a surgical option, but you like to remain optimistic. And then was able to ring them up in 2019 and say, now, I said if I had an operation that I thought might be able to help you, I'd let you know. Will you like to come back into the hospital? Because I believe that we have an operation that can help you with your phantom limb pain. I would never have believed that 10 years ago. So round the corner, who knows what's going to happen next? And I absolutely believe that the TMR is one of the good treatments. There are other treatments such as regenerative peripheral nerve interface, which uses a similar technique of giving a nerve somewhere to go and something to do, and is in fact less intrusive than TMR. So it may be that we'll be doing that next. Who knows? But TMR is fantastic for a lot of patients at this point.
Okay, amazing. Thank you. And the next question is, why did you decide to specialize in this treatment? I think I can tell why after hearing that. But
well, I've been interested in amputation surgery for a long time. I have a very large group of amputees under my care. And obviously, as soon as you hear a technique such as this that has the life-changing potential, then you have to look into it. And I was very lucky to hear about this technique at a conference, to be able to discuss the technique with the person who was doing it out in America. And they came to my unit here in the NHS. We persuaded the local commissioners that this was an operation that the NHS should investigate. And I was supported to start to do this for NHS patients. And so it's an operation that's available in my hospital, both to NHS patients and obviously privately as well.
amazing. Okay, thank you. And the final question, are there any developments happening in your field that you find exciting at the minute?
Well, I think this one is the exciting one, but as I said earlier, the trying to modify this into a less intrusive operation without needing a muscle donor is something else that we're also looking into.
Okay, that's perfect. Those are all of my questions, Ms. Cubison. Thank you very much for taking the time to speak to us today. And for those of you watching or listening at home, if you would like to book a consultation with Ms. Cubison, you can do so via her Top Doctors profile at topdoctors.co.uk. Thank you very much.
Thank you.